We begin this talk by acknowledging that we are meeting on Indigenous land. As settlers, recognition of the contribution and importance of Indigenous peoples must be connected to a collective commitment to make the promise and the challenge of truth and reconciliation real in our communities. We recognize land acknowledgements as one small way of demonstrating respect for the diverse histories and cultures of all Indigenous peoples. Today, I am joining you from Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. I acknowledge them as the past, present, and future caretakers of this land. You can share where you are joining from today, and if you would like to learn more about the land you engage on a daily basis, I encourage you to visit nativeland.ca, and I'll put the link in our chat shortly. The work of truth and reconciliation is ongoing, and we all have a responsibility to each other and this land. I would like to take a moment to thank everyone for joining our virtual presentation today. Our speaker this afternoon is Dena Palamedes, who will be presenting on Not Ticking the Right Boxes, My Experience with Lyme and Co-Infections. Dena, a Clydron patient partner, retired as Chief Audit and Evaluation Executive from Canada Border Service Agency in 2016, after over 36 years working in various federal departments. Dena's experiences include internal audit and program evaluation, organizational change management and civil aviation, reporting to Parliament of federal hiring practices, the recruitment and development of the federal government's internal audit community, policy development and professional internal audit advice to federal departments, and financial services. She is active in the Institute of Internal Auditors, teaches and consults part-time. Dena has a Bachelor's of Social Sciences in Economics from the University of Western Ontario and is a CPA, a CMA, a CIA, a CFE, a CCSA, and CRMA. We will have Dena present, and then we will open for questions from the audience. You can ask questions by entering your questions into the chat box or raising your hand using the icon. Please help us welcome Dena to the podium.
Thank you very much, Lisa. I'll share my screen now. Good afternoon, everyone. Thank you very much for inviting me to speak today. My objective is to share my observations on the current state of the system as it relates to Lyme. To undiagnosed chronic Lyme and co-infections, in the hope that more professionals see us and seize immediate opportunities to make changes in the lives of suffering Canadian patients. And even though we tested, there we go. Unlike most of you who are science professionals, I spent my career in the public service, and my lens includes the work I did as an internal auditor and program evaluator. I just listed some of the areas of expertise. Some were referenced in the bio, but this is how I'm approaching my presentation today. I'm going to split it into about me. I'll begin with an overview of my personal experience and then discuss what I view as the implications for Canadians and make some suggestions for change. I've spent considerable time trying to understand what can be done about the system and how to improve how it addresses chronic or late Lyme diagnosis. My story is very similar to many of those with late diagnosis of Lyme and co-infections. It wasn't my first experience with poorly understood diseases. I have beta thalassemia minor. I am hypothyroid. It took a long time for a celiac diagnosis and 15 years for a diagnosis of severe and extensive endometriosis. There were immune system implications, and it colored how I was viewed by the system. It also left me traumatized. However, I At the same time, I learned to believe in myself and what I understood about myself. In December 2016, as you know, I retired from the federal public service. And during 2017, I picked up small contracts, volunteered opportunities. I traveled across Canada and the US. We went on a few vacations. I began to learn to sail. I traveled to Greece, and I went to Haiti to teach. For a week in July of 2018, I walked the West Highland Way with my family. It was about 225 kilometers. And my best day on the hike was 45,000 steps over mountainous terrain. Using the Public Health Agency of Canada's social and economic influences on health, my overall personal circumstances appeared excellent. In August of 2018, there was a shift. When I visited a friend at her cottage, I discovered I could no longer keep up with her on my bicycle or walking at our usual pace. My stomach, which had always bothered me, hurt more than ever. My sleep was increasingly disrupted. I was losing my strength. It was harder to focus on reading and my little professional contracts. When we went to China in March of 2019, my hands hurt all the time and I could not close them. That summer, I could not hold the rudder on the sailboat. The stomach and back pain increased. My family doctor was sympathetic and made many referrals to the relevant specialists for me. Just before Christmas in 2019, we visited Seattle for a few days. I picked up a cough, which turned into wheezing, where I could find only fits of sleep sitting up in bed with the windows open so that the frozen air could help me breathe. It was pneumonia and several rounds of antibiotics, and I was still coughing in April of 2020. The spiral continued downward. In October of 2020, my right leg collapsed. I fell as I was exiting the washroom. The pain was excruciating and I couldn't get up even with help. An ambulance was called and I was admitted to hospital for 5 days because of several herniated discs. While I was in the hospital, my blood work came out wonky. There were autoimmune and inflammatory markers, but no obvious cause. The naturopath I had been working with since early 2019 recommended extensive testing through Armin Labs. And at the end of October 20, it came back positive for Borrelia burgdorferi, chlamydia pneumonia, Ehrlichia, rickettsia, Epstein-Barr virus, and human parvovirus B19. I know there's questions about foreign labs, but this was the only test I had available to me. At this point, I was unable to function more than an hour or two a day with all the symptoms you see on the slide. By February 2021, I concluded I would not live to 102 like my father, and I began to prepare my personal affairs, including all the necessary when I die instructions for my family. That is how badly I felt. My immune system was unable to keep up and it needed help. Here's a timeline of the major relevant events in my health history, and it's to illustrate that people like us come in with a backstory. I had a very serious episode of mononucleosis when I was 10 years old, and I was hospitalized for 3 weeks. I've always enjoyed the outdoors. I was in the Army, and I spent 4 months in the bush in Gagetown in 1980, and many holidays backcountry camping. However, I'm allergic to mosquitoes, black flies, horse flies, midges, all kinds of flies. And I'm a magnet for them, and I'm covered with many long-lasting large bites after every wilderness adventure. Many of the bites looked like Lyme bullseye rashes if I had known about Lyme disease, which I didn't. I've indicated with the arrows where I know I had bites and subsequent illness. In 2001, we went on a 5-week family camping trip to BC. When I came home, I had headaches and a stiff neck that took many months of massage therapy and chiropractic treatments to ease some of the pain. In 2015, we spent a week in Florida, including a long day hiking. And then after a few days, I was bedridden with a terrible flu that still did not clear for 3 weeks. I then had 2 courses of doxycycline, which helped. But in retrospect, I have no idea why the doctor prescribed it. It seemed I would always recover, but I did struggle with fatigue, pain, and many health issues. Despite this, I was functioning and productive. However, I did not recover from each of the declines in 2018, 2019, and then 2020. And once I was diagnosed in October 2020, it took until May of 2021 to find someone who would prescribe me any antibiotics. I saw dramatic relief of the pain and the brain fog with the first course of doxycycline. I'm still struggling with fatigue, inflammation, and pain, especially in my eyes and my gastric system, and I judge myself to be about 60% of what I was in 2018. In October 2020, my Horowitz Lyme score was 103. 46 or more is high and is a probability of a tick-borne disorder. I had all the post-treatment symptoms and most of the late-line symptoms, and I lived in Ottawa, an at-risk area for Lyme. Specialist referrals often took years and resulted in it's not X, Y, or Z. Complicating this was COVID. Infectious diseases in my community would not accept me as a referral, and suggested root causes included functional diagnoses like IBS and dyspepsia, depression, too much stress, and this is not a joke, swallowing too much air. Menopause, that's just your baseline, aging, and visceral hypersensitivity. Few solutions were offered, and the most common were antidepressants, the FODMAP diet, and CBT for sleep, which is effectively imposed sleep deprivation. My extensive foreign travel was documented, but serological testing was never referred to the national lab. No physician offered to prescribe antibiotics, even with extensive physical evidence, including the arm and test results of Lyme and co-infection. My rheumatologist, who was young and who I liked and who appeared thorough, said 2 things that summed up my challenge with physicians. I don't know about Lyme. It's very complicated. And I see a lot of people like you, but you don't meet the thresholds for autoimmune diseases, so there's nothing I can do for you, so I'll have to send you back to your family doctor and release you as my patient. It took almost 3 years to find an integrative medicine practitioner who could diagnose and treat me effectively, and we're still working on it. The root causes of my illness included Lyme, but the solutions are not simple. I struggled to find what was wrong with me and why I could not get better, and I asked myself, what was I doing wrong? I felt a failure. I could not communicate effectively the depth of my misery with any physician I met. Perhaps I was just weak and negative, or I was not trying hard enough with my diet and exercise. This did not make sense, though. I had done everything I was supposed to do, because we've all bought into this model of wellness that's been used for years, that we have personal responsibility for our health and wellness. And it's up to us to be proactive. It was then I discovered this theory of well-being, which explained it for me. No matter how much is invested in positive determinants of health, they cannot tip the scale if the negative determinants are too heavy. Part of the problem was you only see what you are looking for, and each person's perspective is affected by their experiences. No one believed I was living free of gluten, dairy, and egg, limiting sugar and high FODMAPs. 2 practitioners later said their patients rarely comply. Chronic illness is frequently attributed to lifestyle choices. It's easy to psychologize chronic illness when you don't see or understand the cause or know the person. They did not understand how high functioning I had been with 3 children. As a senior executive with a large team, I volunteered and I engaged in many activities. I was active physically, including running, hiking, skiing, biking, sailing, and then I could hardly get out of bed. And it was easy to believe I was depressed and anxious. But if you're the 15th or the 25th doctor I'm consulting, I am struggling and in pain, and no one has acknowledged that there might be a root cause. No wonder I'm anxious. Adding to the challenge, I am a woman. Asking the right questions and listening to the patient is hard to do when working in silos during 15-minute appointments. I'm not sure anyone I encountered fundamentally believed the person who knows the patient best is the patient. I'll conclude my personal experience with this quote and highly recommend this book to physicians, researchers, and patients alike, because Megan O'Rourke has done a fabulous job of explaining the experience of someone with Lyme and autoimmune diseases. So now I'll move on. And I'm bringing to you a few concepts from my world as I look at how Lyme and the system that treats Lyme is structured, in the hopes that you'll individually see other levers that you can influence. When you start an audit or an evaluation, your starting point always includes an environmental scan, identifying who the primary and secondary stakeholders are and what their expectations and issues are. We also ask, what are the expectations of the program? The public system is there to achieve the expectations of the program. In 2014, the Federal Framework on Lyme Disease Act was passed. It recognized in the preamble what seems to remain debatable in much of the medical community, even today. The Borrelia often persists following the recommended antibiotic treatment. The current serology does not adequately describe the diversity of the bacteria. The general understanding of and practices for dealing with Lyme are no longer sufficient or in line with emerging evidence on how the disease operates. Current guidelines are so restrictive as to limit the diagnosis of acute Lyme disease and deny the existence of continuing infection, thus abandoning sick people with a treatable illness. And the current diagnostic testing for Lyme disease is inadequate, and they advocated placing the highest priority on the development of reliable testing for the disease and on educating physicians so that they can recognize the symptoms in a manner that's appropriate, including treatment with antibiotics as justified. I hope you'll bear in mind this preamble. I'll come to it a little later, but I won't show the slide again. The federal and provincial mandates on health mean that the powers of Health Canada and PHAC are limited, therefore limiting the scope of the evaluation that was done in 2022. But the legislation on the framework did require program evaluation of its effectiveness in 2021. The report is available on the PHAC website. It acknowledged that there is a lack of consensus about the appropriate role of the agency. There are differing views. There is a lack of funding. There are a number of areas where progress on action items has been limited. For example, collecting surveillance on Canadians who do not meet the case definition for probable or confirmed Lyme disease, and where further work is warranted. Many of PHAC's traditional partners reported generally positive impacts of PHAC's activities across the 3 pillars. Conversely, patient advocates saw urgent unmet needs in the areas of surveillance, diagnosis, and treatment for Lyme disease, particularly in individuals who do not meet the case definition. These are the needs they feel are not adequately addressed by the scope of the framework itself. Unfortunately, the recommendations are restricted to what falls within PHAC's mandate, but it did recognize that patient advocacy is very important as our efforts to promote and disseminate awareness and education materials and guidance to existing and new knowledge users, including health professionals. I won't speak to the recommendations specifically other than that one. What I realized when reviewing public materials and issues online is there are dramatically different views on what the objective should be. Here is an old model, the Canadian Institute of Chartered Accountants criteria of control model that lays out what's necessary to achieve the objectives of a process, system, or organization. Firstly, everyone and everything must be aligned on the objective. That includes all the mandates, policies, and plans. Then they must be committed and engaged in achieving that objective. They need the tools, resources, equipment, and authority to achieve the objective. But generally, the actual doing or the action is rarely a problem, except where those actions are not aligned and in support of the agreed upon objective. Finally, there needs to be monitoring and learning that feeds into refining the purpose. When I read the federal framework for Lyme, I realized the problem starts at the top. There is a disconnect between the preamble of the legislation, which intended prevention, detection, and treatment of all stages of the disease, and the components of the framework which address only prevention and awareness. Why is this? So I reflected on what were frequent themes from audits and evaluations that I had done in the federal government. The stories and the issues repeat themselves over and over again. And it's usually the objective where things break down. But these are in no particular order the themes from my career. Who the stakeholders are and what their expectations are is rarely understood. Passionate, well-intentioned professionals often forget to ask, who am I serving? Policymakers, service providers, and public servants think they know best rather than listening to and hearing the primary stakeholders, the citizens receiving the service. Silos and horizontal or shared accountability do not work. If everyone does not agree on the objective, support it, and work toward it, the system, team, or organization will not succeed. That ties back to the criteria of control model I just showed you. There are never enough resources. Perfection is the enemy of the good. Decisions need to be made with insufficient data. Individuals and organizations are risk adverse. Too many controls create the risk of not achieving the objectives. And we are always trying to reinvent the wheel and have a Canadian solution. Innovation, true innovation is rare, and new systems usually pave old cow paths. Root causes of complex problems are never obvious, and one word is understood differently, but it is understood by different stakeholders. How one word is understood by different stakeholders is often a root cause. This happened many, many times. We'd realize in the course of an audit or evaluation how one word made a huge difference on the outcome. And then the best solutions are often found when there is a participatory decision-making process used. Then I looked at Lyme treatment, and I see the same issues. There are likely too many files in Health Canada and PHAC, and they likely have insufficient resources and expertise. Their federal mandate limits their ability to address the many, many issues. The key primary stakeholder is the Canadian Lyme and co-infection patient, whose options are restricted by legislation, regulation, jurisdictional mandates, diagnosis, treatment, and access to services. Primary and secondary stakeholder perspectives and objectives are dramatically different. Responsibility, leadership, and accountability and authority over the Canadian medical system is siloed with limited accountability to Canadians. Research and medicine evolve at a glacial pace. Patients are on the periphery of decisions related to medical research and delivery. And money drives decisions and influences behavior in ways that we often don't see. Government, big pharma, and insurance are all affected by money or the lack of money. Chronic and undiagnosed Lyme and co-infections are not adequately addressed through any public mandates. And Canadian medical practitioners are not resourced to recognize and deliver effective diagnostic and treatment services to Canadians living with chronic and/or undiagnosed Lyme and co-infections. Virtually all public resources allocated for Lyme and co-infections are spent on research, surveillance, and prevention. Unknown thousands of Canadians are living with the consequences of diagnosed and undiagnosed Lyme and co-infections with no hope. It's not clear which specialty should be treating Lyme and co-infections, and the Semmelweis reflex is at play. This is a behavioral tendency to stick to pre-existing beliefs and to reject fresh ideas that contradict them despite adequate evidence. I believe it's a critical issue, and most medical professionals have been taught that Lyme disease is rare and can be cured by a short course of antibiotics. Thinking about these issues had me going back to basics. What is a system? It's an organized, purposeful structure consisting of interrelated and interdependent elements. It's created by management, which means leadership is critical to achieve an objective, to solve a problem, and it's meant to dynamically prevent, detect, and correct hazards, threats, and risks. Leadership, I have to reinforce, leadership or a single point of accountability and authority is essential to the success of any system. Some of you may be familiar with James Reason's Swiss cheese model. We used it at Transport Canada. When a system fails, it's usually and more often than not that risks materialize and result in various injuries, not from a one-time situation, but from the results of systemic failures. We can use this analogy when we look at how our body defends against Lyme, but it's also an analogy for how the medical system treats Lyme. And it's important to reinforce that surveillance and prevention are only one layer of defense when we're looking at systemic failures. Materialized risks require remediation. I've tried looking at the problem of Lyme using multiple models of risk management. After all, we are here because of the risk Lyme presents to Canadians' health. The US National Institute of Standards and Technology, or NIST, cybersecurity framework is the gold standard for cybersecurity threats. It combines prevention, detection, recovery, and mitigation. Another model of systems is the Deming's Plan, Do, Check, Act model. As you can see, leadership and accountability is central. When I take this up 30,000 feet and look at Lyme risk management, it's missing detection, mitigation, recovery, leadership, and accountability. Again, I asked myself why, and I pulled out some of the training materials I use for a course I deliver on safety management systems. Even though transportation regulatory safety has both provincial and federal components, the licensing and certification is provincially managed. The critical regulatory oversight happens at a federal level, and accountability is to the Canadian public through the Canadian parliamentary system. In medicine, the provinces control the delivery of services. The profession is managed and oversight occurs through societies and colleges. Universities are leaders of research and training. There is no single point of accountability to the Canadian public. What I learned from change management theory is that to truly create change, you need to create dissatisfaction. Have a vision of what could be and implement the first steps before you can overcome resistance to change. So if I have not provided you with enough evidence of dissatisfaction, I'll add a little more. The former Canadian Senator Kelvin K. Ogilvie said, "We have a system fraught with multiple professional silos, often conflicting and at best simply not collaborating, and we have no system for identifying best practices wherever they occur and disseminating them across the system. There are silos among the research disciplines. There are silos between clinicians and researchers, social scientists and biological scientists, doctors and nurses. And there are silos between the public and the private sectors." So what happens in silos? No one looks at the big picture, including all the risks. There's no systems thinking. There's no accountability to the primary stakeholder. No one is responsible when you have a multi-system chronic illness. Each silo thinks they know best. Root cause analysis does not occur across the system, and solutions are not multi-systemic. The big picture is big, and the numbers I see regularly referenced do not make any sense. By the way, I was very pleased to see Dr. Kadir's analysis on Tuesday, which challenged those regularly quoted numbers. In my work, we frequently use proxy measures because it's often impossible to get any numbers or absolute numbers. I also know that it defies logic that ticks stop at the border. These numbers, and I underscore, these numbers only relate to Lyme disease. What is quoted is that we have 2,168 Canadian cases in 2022, and the US reported, the US had 30,000 cases reported. However, the CDC estimates 476,000 people are treated for Lyme annually. I also would like to reference the study done by in 2018 by Vet Lloyd and Ralph Hawkins under detection of Lyme, where they found that there is a minimum of a 12.1 to a 58.2 fold underestimation. Therefore, remember I'm using proxies, the annual Canadian Lyme cases could be between 26,233 and 126,178 using that above study. Or if we use the old 1/10 of the US, at least 47,600, except the majority of the US cases are along the Northeast US-Canadian border. There was also a study released in 2022 that estimated the global Borrelia burgdorferi, seroprevalence was 14.5% of the population, suggesting between 5 million and 6.3 million Canadians have been exposed. Canada does not have an estimate for how many people actually have Lyme and co-infections. Essentially, 1 in 7 Canadians have been exposed to Lyme disease, if you're to believe that 2022 study. I'll add one more consideration. In September of 2022, a Polish study revealed that all patients hospitalized due to COVID-19 disease were positive for Borrelia burgdorferi. We have a public health crisis that we are not acknowledging. And the costs to society include direct and indirect costs, healthcare, social benefits, and lost productivity. There are costs to the individuals and their families, which are enormous, many of which are not acknowledged and cannot be measured. I am functioning at the level I am functioning because I'm able to pay for it. In the last 5 years, I've spent $58,000 in Canada for medical care, some of which fortunately was covered by my private insurance. I'm still out of pocket $28,000. This is in comparison to what OHIP spent on me in the last 7 years, about $12,000, which included that 5-day stay in the hospital in October of 2020. This doesn't include my indirect costs, my lost income, and the quality of life. And every day I think about the people who are ill and in anguish and do not have the financial resources and skills to obtain a diagnosis and treatment for their disease. More must be done to reach Canadian physicians so they feel confident they can treat Lyme patients and it doesn't present personal and professional risks. I believe the current communication efforts by the public health agencies are reaching the public more effectively than they are reaching physicians, because those physicians' primary resources don't contain the messages they need to diagnose other than acute Lyme, if that. And I did a personal survey and I asked, what are your sources? And now A was the go-to resource, and it's limited. The first steps to any change management effort is to understand the environment and acknowledge the client. We still have a long way to go there. A change journey takes time. People must let go of their old beliefs and habits and embrace a new vision. Initially, only a few accept the new vision, and it takes a while for the majority to engage. Some will never accept a new way of working, being, or beliefs. We have yet to engage a critical mass of individuals in the medical and research community and the public health officers who can lead change because of all the barriers I've shared with you. There is some hope. On May 3rd, 2023, the Ontario Public Health issued a comprehensive Ontario Lyme disease investigation tool. I hope it will be quickly distributed to all physicians and they will feel empowered to change their views on the prevalence and treatment of Lyme disease. But yesterday I took a look at the Ontario College of Physicians and Surgeons website. It did announce in March that it was coming, but it didn't have a link to the new tool. And I don't know how attentive physicians are to the newsletters that come from their college. In closing, Canada's health system is broken for all Canadians, but it doesn't exist for chronic and undiagnosed Lyme and co-infection patients. There's an enormous personal and societal cost that's continuing to grow. And I would urge you to ask, how will what I am doing actually and directly improve the lives of individual Canadians? The root causes of Lyme include Lyme, but are complex, as are the solutions. And leadership from government, the research and medical profession is required because of the subordinate place that patients exist in this dynamic. And that leadership is required to acknowledge chronic and undiagnosed Lyme and co-infections exist, and it's a big problem. Recognize that the time required in the current evidence-based medicine system model is not providing any medicine to those who are suffering right now. Accept more risk at all levels when considering this patient population. Invest in understanding not only the scope of the problem, but diagnosis and treatment, and determine who is responsible and accountable to patients. And I'd leave you with one last thought. Imagine what would happen if every physician was expected to ask, could this be Lyme and/or co-infections with a patient presenting with multi-system issues, pain, and fatigue? Thank you. Are there any questions?
Dena, thank you for your presentation and for shedding light on how to improve policy and system practices in the area of Lyme disease. You've really drawn attention to areas where change can occur, and you've brought a distinct lens for understanding how we might approach change making. So thank you so much for your presentation. And I just want to open up the conversation to others. So we're accepting questions right now in this Q&A period, and you can feel free to type your questions in the chat box, or also raise your hand and unmute yourself to ask a question. Rob Kulati.
Hi, thanks for that talk. That was great to hear your perspective. And what I was thinking of is so our network is research. It was developed as a research network. So I'm curious to hear your thoughts about as we think about where we're going forward in the future for the network. What are the areas of where research might be needed to help motivate some of these changes that you're discussing?
Oh, I really like that question. Thank you. I think quantifying and endorsing a view that the scope of this problem is much larger than is acknowledged. It's hard to work with the data that's out there right now, but I was thinking just yesterday, the labs receive all sorts of Lyme requisitions, and does anyone in the public health agencies receive data on how many Lyme tests are requisitioned and how many are positive, how many are questionable, and how many are negative? And with those tests, there's no information on for the Western blot portion on the bands, so doctors can't interpret. There's no additional interpretation available to physicians. I think there's probably a lot of data out there that's not being accessed because of how we have all these layers of government, and the people that make the decisions to contract for services might not be embedding options to pull data out of particularly the labs. There was another part that I wanted to share. I don't think the network's pillars were aligned to the pillars that came out of the legislation. And I wasn't there when the preamble was drafted and then the legislation was drafted. So I don't know what the negotiations were. around the words that went into those 3 pillars. But as you can see from the risk models, there are significant components of the medical system and Lyme and co-infections that are missing for any system to be successful. And it always starts at the top. However, the reason why I share my views is in the hope that you can take opportunities that are presented to you. And one opportunity is when you go to seek grants is to go broader than what you think your scope is. Don't restrain yourself as much because you're already being restrained by policies in your university and policies by the provincial health officer and policies, you can only use pre-existing authorized tests. Be brave and because there's a lag, like I don't know what the time lag is for the research, but I would suggest it's 15 or 20 years if I'm looking at, for instance, gastrointestinal research, how it gets to actually be delivered to the patient now. I hope that helps answer your question. Thank you.
Yeah, thank you.
Thank you.
Dr.
Yeah, I saw that Dr. Amir Kadir has raised his hand, and then following that, we'll have a question from Terry as well.
Oh, we can't hear you. Still can't hear you.
Dr. Kadir, we can't hear you.
Okay, so I guess he's rebooting or doing some troubleshooting. Oh, he's going to write the question.
I think maybe writing or typing.
Okay.
Okay, so while we're waiting for that question to be written up or typed out, we'll, I guess, accept a question from Terry.
Hi, Dena. Thank you so much. That was a wonderful presentation and what an incredible speaker you are. I'm just wondering if there's enough data, enough information to support the theory that patients aren't failing therapy. Therapy is failing patients. Can we say that at this point in time? Thank you.
I don't know the word, what exactly you mean by therapy. Maybe you could clarify that.
Well, it seems like Lyme patients go through the mill and don't get diagnosed, or when they do, it's often not appropriate therapy. It's not treating the infection. So when physicians take that approach, that therapy is failing the patients, like they're not accessing the care that they actually need. And it's creating a bigger problem for the patients. You know, thanks, Dena. I'll be good.
I get you now. Okay. So there's a technique we use in internal audit, and that's called root cause analysis. And there's a very simple approach to root cause analysis that's frequently used, and it's the 5 whys. And you ask why am I sick? And you end up with a proximate cause. And it's often not the real cause. And then you ask why again, and you might end up with another proximate cause. And then you start asking why and why and why, and you get lots of potential causes that give you, it's a brainstorming exercise that give you lots of data to assess, is it one cause or multiple causes? When I look at organizational systems, it's multiple root causes. It's never simple, and there are multiple root causes. And the answer is never evident when you first look at the situation. And I do think that they're easy go-to answers that because of diagnostic pathways and, you know, look for horses, not zebras, those kinds of expressions. For example, I was looking at the diagnostic criteria for depression, and I meet every single diagnostic criteria for depression except suicide ideation. No wonder people kept on offering me antidepressants. And I would posit that in Canada, we have an awful lot of people that have been diagnosed with depression that are taking antidepressants, and the root cause of their illness is a bacterial infection, a vector-borne infection, probably Lyme or a co-infection. So yes, I think because of all those things I shared with you, all those system concepts, the system is failing everyone. And it's failing the doctors, it's failing the researchers, it's failing everyone. And we're not getting the treatment we need. Thank you for the question, Terry. And I don't see if Dr. Amir has been able to, or Dr. Kadir has been able to put his question in the chat, or his hand is still up, so.
Dr. Kadir, maybe if you could just let us know visually, possibly if you're still writing up a question, or.
I'm just re-admitting him right now. Maybe he's joining by his phone, so just give it a second.
Okay, thanks, Veronica.
Oh, we can't hear him again. Oh, but he's connecting to audio. Maybe it'll work.
Thank you for letting me in again. Thank you, Dena, for your very clear and impactful presentation. To follow up on Professor Colati's question and your answer, having in mind that we ought to overcome resistances that are institutional, that are conceptual, and are really related to the complexity of the disease itself and of our poor understanding of these complex infections and their autoimmune consequences. To overcome these resistances, we have also to, as you mentioned, to have some first steps. So maybe what I can suggest to responsibles of different pillars to come of the Clyde-Ren is to envisage to set up a national, or at least in Ontario, in Quebec, and in maritime provinces, a register, a clinical register, as I presented to you 2 days ago, with appropriate, of course, we need to set up this register in a manner that would be consistent with the work of Clyde-Ren and also with the new network of clinics that will take care of chronic Lyme patients and long COVID patients in Quebec. We can set up a clinical register with an appropriate approach so that we can begin to envisage antibiotic intervention, but some other interventions that are already plausible and possible that can be worked out, but at least to allow within a structured framework of research, observational research, allow interventions by physicians, by nurses, practicing nurses, and by pharmacists involved in this network to begin to evaluate. As I mentioned in my presentation, we have, of course, people who have had demonstrable Lyme disease by standard serology, or at least by a clinically observed erythema migrans, for instance. But we have also all those other cases that by all means are possible, not in the sense in absolute possibility, but really a plausibility of infection because of strong epidemiological evidence. And if we can convene on a consensus of acknowledging this possibility, we can begin to act on those first steps that are needed to understand better to have a better evaluation of the scope of the problem, then because we will then be able to recognize these instances, these cases, and have a how do you say, a register of the to have the appropriate numbers and begin to act. I don't know if it is compatible with your view, Mrs. Palamedes.
Well, I am thrilled that someone who's leading in this area recognizes that there are levers that you can still engage, that those possibilities are available to you. And it makes a lot of sense to track not only what you are confident about, but what is questionable. So it's almost like though that bullseye rush, you know, in the center is the line, and outside it is the plausible, and outside it is the possible. And if we could understand not only the actual and the plausible, but also the possible, you're starting to work with data that is more compelling for policymakers and engaging people in changing their narrative. But it's also risk. People feel great risk in going beyond certainty and changing their risk dynamic for them.
Yeah, but remind you that all of us physicians, for example, involved in this area are also subject of a lot of pressure from our associations, because there is judgment, even if that the paradigm is slightly changing and shifting and opening up, but there are still a lot of misconceptions. So in that regard, I understand that some of my colleagues, doctors of infectious disease or other specialties, are hesitant to get involved. But if it's in a structured manner within the framework of a network like CRY-LORRAINE, with its appropriate federal, I would say, credibility, and also with this new network that we're going to try to set up appropriately in Quebec, I think within this framework, many colleagues are ready to step in and envisage such type of approach, which would be in fact defining chronic Lyme disease in an operational manner until we have a more strictly defined scientific manner.
May I just add one thing? And that's early on, I said like one word matters. And one of the huge gulfs is what the word Lyme is to the professional community and what the word Lyme is to the patient. And the word Lyme to the patient is, I am sick. There's lots of things that are wrong with me, and I need help with all of those things. So it's not just the bacteria, and how to shift it to a larger word for the community that's trying to help people get better.
Agreed.
Thank you.
I think that's actually a really great point to sort of wrap up. It is 1 p.m. right now. So thank you everyone for attending today's talk and for asking these questions. And big thanks to Dena for your presentation today and making this possible. And Veronica, I'll turn it over to you.
Thank you so much, Lisa. Thank you again, Dena, for your presentation, and for Lisa today for helping to moderate today's event. I just wanted to remind our audience that we are continuing our talks this month. Our next presenter is Dr. Marty Ross, who will be presenting on Tuesday following the long weekend at 1 p.m. Eastern Time. His talk is Hacking Lyme Disease, Action Steps to Recovery. So we hope you can join us next Tuesday, May 23rd at 1 o'clock. A reminder to take part in our challenge, wear green, take a photo and share it with us to help raise awareness for Lyme disease and tick-borne diseases. You can send your photos into clydron@gmail.com along with your name and email. All entries received will be automatically entered into the draw, which will occur on May 31st at 1 o'clock for a chance to win one of 4 $25 Starbucks e-gift cards. If you're like me, who doesn't like their photo taken, but you are an artist out there and have works of art, whether it's poetry, whether it's paintings, drawings, pottery, take a photo, submit it. It'll be entered as well into our draw. And finally, our TICNEC Canada Scientific Symposium will be occurring in Toronto, Ontario on October 24th and 25th. We're hoping to get registration abstract submission opened up in the coming weeks. The planning committee has been working hard, and we hope to have more information before our events wraps up later this month. And we are aiming for a June 1st open date. So stay tuned for more details. Again, thank you to Lisa and Dena for today. And thanks to the audience for joining us. Hope you guys have a fantastic rest of your day and leading into a long weekend here in Canada. Hope you have a great long weekend. Stay safe, everybody, and we'll catch you again next Tuesday, May 23rd. Take care.
Thank you, everyone.